My name is Dr. Andy Lee, and I'm the neuro-ophthalmologist here at Houston Methodist Hospital. And today we're going to be talking about the optic nerve. And when you have nerve damage in the optic nerve, we call that optic neuropathy. Pathy means disease, and the disease is in the optic nerve. So as you know, the eyeball with the retina receives the light and then sends the information back, and that structure is called the optic nerve. So the optic nerve carries the information like a telephone cable from the eyeball itself, from the retina to your brain. And today we're just going to be focusing on this part right here, which is called the optic nerve. When we look in the back of the eye, we can see the optic nerve. So when you go to the eye doctor and we dilate patients, we can look in the back of the eye and see the optic nerve and the blood vessels coming out and the center part of your eye. And so when we're looking for an optic neuropathy, we're going to be looking at decreased visual acuity, decreased visual field, a relative afferent pupillary defect, which is a defect in the pupil pathway relative to the fellow eye. So when we shine the light in pupils, they're normally the same size, and they're, in this case, mid-sized pupils. When we shine a light into this right eye versus this left eye, then both pupils will constrict to the light. And then if we swing the light from the right to the left and then back to the right, if there's a defect in the optic nerve, the light won't be sensed the same amount in the involved eye. And so this pupil, instead of constricting, will dilate. So when we swing the light from the good eye to the bad eye, we get this relative afferent pupillary defect, a dilation rather than a constriction relative to the fellow eye. So that's a super important finding. It's the only objective finding that we have, that there's an optic neuropathy here. And even though a big retinal lesion can produce it, it usually means optic neuropathy, especially if you already looked in the fundus and you didn't see anything. And then the optic nerve has only two pathologic responses to disease, which is good. It can either swell, or it can become pale, or it can be normal. So when we're looking in the back of the eye, if we see the optic nerve is swollen, or if the optic nerve is pale, or even if the optic nerve is normal, as long as we have the RAPD, these are the findings clinically that we have an optic neuropathy. And so most optic neuropathies, if you're acute, if you are an acute optic neuropathy and you're young, that's usually optic neuritis, inflammation of the eye nerve. And if you're old, anterior ischemic optic neuropathy, that's a stroke in the eye nerve. So if you just knew those two, optic neuritis and ischemic optic neuropathy, you would know most of the acute optic neuropathies that occur in adult patients. So you need to know how to diagnose an optic neuropathy. You're going to check the vision, do a visual field, swing this flashlight for RAPD, look in the back of the eye, making sure it's not the retina, and if the optic nerve is swollen or pale, that is the defining clinical features of an optic neuropathy. And in adult, for young patients, that's usually optic neuritis. And for older patients, especially if they have vasculopathic risk factors like hypertension, diabetes, high cholesterol, that's anterior ischemic optic neuropathy, the stroke in the optic nerve.